Ramesh.
Hello.
Hello. How are you?
Hello, Pablo. Oh, I haven't seen you for some time. How are you? I
Yes,
missed you.
last time I wanted to visit you in Singapore, you were not there.
Twice I missed you.
How is life?
Yeah, good. Are you going to Sofia?
Yes,
Yeah, I'm flying on Thursday. Yeah.
Thursday.
No, but it takes me a day to arrive.
So you will be there on Saturday or Friday night, something like that.
Friday, yeah. Friday I'll be there.
I'll be landing there on Saturday midnight, 2
Okay.
a.m. 2 a.m. Sunday, indeed.
Okay, I see you Sunday then. Yeah.
So let's
Yeah.
call each other. Huh?
Yeah.
Thank you, Ramesh, for joining us today. It's
Oh,
very
of course.
special to have you.
Of
So
course.
we are planning 2 short sessions, and we were thinking that after the first or second session, you could have a discussion.
Yeah, after the second one, yeah? Or
maybe after the first. So Henry and Vinshu,
yeah,
see
okay. Yeah.
Grüezi. Wie
Hello.
geht's? Wie geht's? Alles gut?
They're good.
So you speak German also, Ramesh?
Ja, ich verstehe, aber ich spreche wenig. Ja, ich verstehe.
Thank you, Henry.
Alles gut bei euch?
Yeah, good.
That's very good. Here it's Solala. My mother died 2 days ago. She's 96.
Oh, no.
She became, but then finally, in the last 6 months, you felt that his biological end will come. And we managed alles that she peacefully slept. That were all good.
Mm.
But nevertheless, it's a loss, huh? The mother.
Of course.
Yeah.
But for the person, it's, you know,
Yes. It's a relief.
Yeah.
So, who is starting today?
You.
Good. I just
Ramesh.
show some cases of aneurysm, some not so frequently observed ones. Is that okay?
Hi, Ramesh, Pablo, and Henry.
Oh, hello.
Good to see you.
I do apologize. I'm in an airport lounge and there may be some noise, so I'll mute myself.
Yeah,
Thank you,
good. When you present, then you should be a little bit louder than the noise.
I hope so.
That's perfectly fine, Henry. That's perfectly fine. Indeed, it's Vladimir and Ramesh will be moderating you.
Good.
That's scary. Because I have right now an emergency, so I will be in and out.
Good. All right. No, I just finished in time perfectly.
Henry,
Moderator,
Ramesh.
Hello.
Hello. How are you?
All good.
Good. Great. Ramesh?
Yes, great. Yeah.
Very
So
good.
good to see you.
Good to see you.
Vlad and Ramesh, do you have the program with you?
Yes, sir.
I have, yes.
Yeah.
Thank you.
Yeah. Henry is the first.
Yes.
Soichi, the second, Abidha, and Ramesh. Ramesh, hello.
Hi, Vladimir. Good to see you.
Where are you?
I'm in
Where
Heathrow. Heathrow, flying to Verona. There's a meeting which I'm teaching.
Ramesh, do you need to speak first after Henry?
That will be fantastic. Then I can be a bit more relaxed and wait at the gate. Now I'm at the main lounge here.
Is that fine, Vlad, that Ramesh speaks just after Henry?
Sure. If Henry doesn't care, and I hope he doesn't. Soichi is with us. Hello, Soichi.
Soichi.
Hello.
Hi, Soichi and Vinshu.
Hello.
Good to see you. How are you?
Hello.
Good to see you.
Good.
Hi.
So Ramesh will be the first, and then we go as it is. Henry,
Make
Soichi,
sure that Henry
and
is fine with
Abida.
that.
Henry.
Hello, Pablo. Hi.
Hi, Vinshu. Good to see you.
Hi. Good to see you.
Thank you.
President, what is? Mr. President, what is your request?
I was asking myself, if do you mind if Ramesh, who is in the airport waiting for the plane, can speak just before you, and you are the second.
Sure, I'm flexible.
To be German.
Only the endoscope is rigid, but I'm
He's
flexible.
kidding. He's kidding. He's not flexible. He's German.
That's why
That's
I'm
impossible. Why
That's
don't you
why
give
I'm
your
asking.
lecture in German, Henry?
Yes, it's
Yeah,
my pleasure.
why not? Good.
Anyhow, it's just video, so it doesn't matter what I tell. It's okay.
Thank you.
Ja. Dann kannst du Deutsch sprechen doch.
Ja, das mache ich gern.
So I'm just opening the YouTube, and I will join you later on. So Vladimir, if you don't mind, with Ramez to take care of the moderation.
Okay, okay.
See you later.
Take care of your patient.
Thank you. I'll be here.
You come. Okay, we have another 4 minutes to go. Ramesh, the connection
Yes.
is good in Heathrow. You look well, rested and
I am using the
happy.
Wi-Fi here. So.
Good. Ramesh, where are you? Singapore or?
Yeah, Singapore. But after tomorrow, I'll fly over to Sofia for ENS.
Oh, you do go to Sofia for the IANS.
Yeah.
Good.
I've been many years with my parents. I was young, so it's nice to see it again.
I've been there some 5 years ago or 6, and the meeting was in Todor Zhivkov. That was their communist president, you know.
Yeah.
It was a palace on a lake close to
Yeah.
Sofia. It was a nice place.
Yeah, I've
A
been
terrible
there in
feeling.
the 70s. Yeah.
Yeah. It's not bad now in Bulgaria. It's
Yeah.
not really that bad.
Vlad, we missed you in Romania.
I haven't been there. I was ill.
Oh, yeah.
I actually had a terrible abdominal surgery in July, and I'm still recovering.
Oops.
Yeah, somehow and somewhere I got a calcifying pancreatitis. So they had to resect the pancreas, they had to resect the duodenum, they had to do the bypasses, they took gallbladder on the way, so it was really terrible.
That sounds
I lost
good.
15 kilos.
That's a big
but now
surgery.
I'm fine. Very big. The biggest they have in abdominal surgery. 6 hours.
But for that, you look good.
Yeah, and now I'm fine already. I feel well. I'm beginning with the sports, and I'm really in a normal condition, or I feel well.
That's
I think
good.
The
the
only
most
bad
problem,
thing-
the biggest problem for you was no smoking in the hospital, right?
No, I did smoke there.
You did. You did.
Yeah. When I was leaving hospital, I thanked my internist that he didn't prohibit me smoking. And he just said, it doesn't matter anymore. You know, the worst thing that I lost 15 kilos, but that was muscles, you know, not fat, but muscles. So I'm now gaining some strength again.
Yeah,
But I'm doing fine.
Okay.
that's good. Alhamdulillah.
Yeah. That was a bad 4 months or 3 months were bad.
Yeah, I can imagine. Pancreas is not nice.
No, it was not, I can tell you. I can tell you it was not. All right, gentlemen. We have 3:59. Shall we start?
Yeah,
really
please
on
do.
time?
Please go ahead, Vladimir. You
will.
can start off, and then
All
we
right.
can.
All right. Hello, everyone. Hello at the next IANA webinar. I do not know which it is, probably 14th or 15th.
I think 12th, I think.
12th.
Yeah.
All right. And this time we have chosen the vascular topic. So we shall have 2 sessions. The first session will be on aneurysms, which is, of course, primary neurosurgical issue. And then we shall have Moya Moya, cavernomas, and AVM in the second session. So let's start. Let's not be talking, just welcome. And first I shall ask Professor Ramesh Nair, who is on the flight to Verona. So he has the privilege to speak first on aneurysm. Ramesh, please. 15
Thanks,
minutes
Vladimir.
each, and I shall, let's say, warn you in your last minute.
Okay, thanks. Thanks very much. And I do apologize if you see any noises, background noises here. I'm going to start sharing my screen. Let me know if you see my screen.
No?
Not yet. Let me just show it. Okay, 1 second. Give me a second. I'm just trying to get the screen sharing option. Sorry, try again that. Share. Can you see my screen now?
Yes.
Okay, give me a second. Yeah, I'll make it bigger. Okay, maybe this one. Is it full screen or?
Good. It's okay, good. Ramesh. Good.
Are you sure? Yeah. Okay. So essentially, my topic is to talk about the ACOM aneurysm. So I'm going to talk about certain surgical nuances over the years I have noticed in operating on ACOM aneurysms. So I work at the Imperial NHS Trust, mainly at the Charing Cross Hospital and St. Mary's Hospital in London. So when I look at the CT scan of a patient who had a bleed from an ACOM aneurysm, you can notice certain patterns. First of all, some of the hemorrhages are often very typical flame-shaped hemorrhage starting from the ACOM region and then extending into the frontal lobe. Some of them can really go into the third ventricle. So you often see third ventricular hemorrhage. Very small leak can often be missed. And only when you look at the third ventricle or the occipital bone, you can find the bleed. And if you see someone who had an episode of headache, and then you find a delayed scan and initial diagnosis was missed, you might often see hydrocephalus, just hydrocephalus, nothing else. And then you have to keep that suspicion of an possible ACOM bleed in your mind. And often these hemorrhages around the interhemispheric fissure or generalized diffuse subarachnoid hemorrhage, where you may not know which one really bled, especially if patients had multiple aneurysms. And from a surgical point of view, I'll be thinking about how much the brain is going to be swollen when I operate. So you need to understand that from the CT scan, and also look at the amount of hydrocephalus, whether you need to do a preoperative drainage of the CSF or intraoperative drainage of the CSF, and the hematoma, also to the nature of the hematoma and how bad the frontal lobe damage is. That can determine your side of approach. If you have a CT scan with the bone window, you need to look at the frontal air sinus. My intention will be to avoid breaching the frontal air sinus as much as possible. I found using 3D angiograms, both 3D CT angiograms as well as distraction cerebral angiograms, very useful to note the bony anatomy and the shape of the aneurysm and the geometric pattern of the aneurysms. Even though you can see that this is the right side, the right A1 here, you see the aneurysm here. But on the other side, you see the aneurysm with the small bleb on the other side, which is hidden. So this is your operative view here. And when you go on to the right side, you will not see the opposite bleb. So in ACOM surgery, many things are blind. Some of the vessels, like the contralateral A2 may be blind, some of the recurrent perforators or the hypothalamic perforators may be blind. So you've got to understand and study the angiographic anatomy extremely well to perform a successful operation. And in the 3D angiogram, you look at the morphology, the projection of the aneurysm. That might determine your side of approach. So there are a few things that can determine your side of approach. One is the dominance of the A1 and also the projection or which side of the brain is damaged. You may want to utilize that that approach. So for this aneurysm, you can see the how the brain is swollen. So I've seen many, and especially when they start off their vascular surgery, they try to be more forceful. That is a bad thing to do. In cases where I've seen such things happening, where they try to retract the frontal lobe very forcefully, invariably the outcome will not be good. And here I'm trying to gently move along with the pulsation of the brain. You know, you don't push it down when it's pushing up against you. You push it down when it sort of goes down. And then in all cases, you should be able to get to these subfrontal spaces without a lot of damage to the frontal lobe. And once you get to it, it's all a matter of opening up the cisterns and waiting patiently for the CSF to come out. The right carotid artery, optic nerve is here. And then it's a matter of releasing the frontal lobe from the optic nerve, and also a proximal film fissure dissection can ease. So here I'm showing you, if you haven't drilled off the base, you will be struggling against that frontal base. Here, you can see the aneurysm being exposed, but this is only the exposed surface, but I won't be seeing the opposite side. So once I clip this, you can see that the contralateral side needs another clip from the underside of it. So this is the other side of it. Part of the aneurysm is blind, so I have to reach with another clip almost to the first clip I put. So these are some technical nuances one has to be aware of when clipping the aneurysm. And this is one instance where you may have to use more fenestrated clips than many other aneurysms. And you can see that the aneurysm is clipped without any concern. And again, another case where you can see this is a more recent case, in the last 3 months or so. You can see the 3D angiogram to show you the bony anatomy and the location of the aneurysm. Studying this aneurysm can tell you how it's going to be during the operation. The A1 is here, and the ipsilateral A2, contralateral A2. So if I'm going to expose it like this, I'll be seeing the ipsilateral A2 directly in front of me, and the contralateral A2 deep. So then the clip is going to be above the ipsilateral A1. So then I can use the clip blade to go above the contralateral A2. So this is kind of planning. You can also see like a nubbing, which is going to the base. So one has to be careful, especially in ruptured aneurysm, that you don't want to retract the frontal lobe too much, especially if there is a possibility of this dome getting stuck against the planum or the optic chiasm. So then that is something which you have to be careful. So this is what you find when you open. This is the left side. Here you can see that the optic chiasm is being exposed. The careful dissection of the arachnoid can a sharp dissection will get you a clean field. And then once you get that exposed, you see the A1 coursing across. Then the temporary clip, placement of temporary clips, as in any aneurysm, you need to decide where is the best place to put the temporary clip on. You better avoid occluding any recurrent. This is the recurrent perforator that is going behind. So you want to preserve all this. This is the ipsilateral A2 here with a branch coming off it. So here you can see in the deep depth, you can see the contralateral A2. So my clip blade is just going above it. And then I'm crowding up all the available sac to leave as less possible as like a dog ear. And once you've done that, then you can have a small bit of a small neck here, which can be clipped. That's tiny clip. You can see the mini clip going onto that. But some of the aneurysms are slightly more challenging. This young man who was working as a concierge, this was in 2016 or something, had a bleed, and initially was coiled. So you can see the aneurysm here on the ACOM from the right side. This was coiled. And then 6 months later, there is some filling, compaction of the coil. And 2 years later, there's a proper neck recurrence. For some reason, he never came back for treatment. And then 9 years later, you have a persistent neck. This was a concern given that he is young. And the plan was to consider surgical intervention. When you consider surgery for recurrent ACOM, especially after coiling, one has to think of a few things in mind, whether what sort of coil was used, whether they have used any intrasaccular device, or whether it was a stent. These things are of paramount importance. And in this case, some of the coils may be looping back into the neck, which may affect the suitability for clipping. So when we talk about the endovascular vessel surgery, there are certainly several indications to consider surgery in certain aneurysms. Not all aneurysms are endovascularly treatable, especially in the acute setting. And also in young patients, if they can be coiled or with stented with some difficulty, it may be preferable to consider surgical intervention to avoid long-term anticoagulation in young patients. And there are a few approaches we will be looking at. One is a TNL approach, and there are the supraorbital approach, or including orbitozygomatic approach. And many surgeons use this as approach, supraorbital mini craniotomy, as a standard approach. And occasionally one may have to consider an interhemispheric approach. I will skip all this, but this is mostly relevant to the ACOM aneurysm. If it's on the left side, I try to become slightly more generous with my craniotomy, so I have more space for the maneuvers and instruments. And the frontal air sinus, I have mentioned about it. And we'll skip this. So again, this is what I illustrate here with it's a small opening. You don't need to expose a lot of brain here. And gentle retraction of the brain can lead you to get to the optic nerve and the optic nerve system and the carotid system. Here you can open up the cisterns to get to the aneurysm. So here I'm opening it. High magnification. This is the right side. Carotid is behind the optic nerve here. And this is the recurrent aneurysm. So I'll just fast forward it here. Here, it's important to understand the anatomy behind the ACOM aneurysms. It's a complex network. This is the ipsilateral A1, and the ACOM junction is here. The aneurysm base is right here. You can see the aneurysm base here. This is a recurrent coiled aneurysm. You can see a loop of coil. So your clip will be above the coil here. And in addition, there was another aneurysm which was missed during the workup. There was another aneurysm around the A1, A2 junction. So that was not visible in the previous. So temporary clip as close to the aneurysm as possible. So if there is any branches coming from the A1, you can avoid it. This clip is going just at the neck of the aneurysm, just avoiding all the coil loops. And we will just skip through that. And then finally, the superficial aneurysm, this aneurysm is clipped. Second aneurysm is clipped at the final step. You don't clip this one and then go back and clip the other one. You clip the deeper one first, which avoid any conflicts with your. So use the intraoperative angiogram to confirm the clipping. So this is and we talked about all this. And so it's important to view the aneurysm in all the views so that you get. One other thing which I wanted to mention here is the projection of the aneurysm. In some of the aneurysms are projecting anteriorly or inferiorly, stuck to the optic chiasm or the floor, or posteriorly. These are slightly difficult. This is superior projection, and posterior projection can be a bit more difficult because many of these perforators, hypothalamic perforators or perforators to the optic nerve may be hidden. So that needs to be looked into. I will skip all these steps for ACOM aneurysm. And some of the A1 can be quite medially looping. So one has to do a lot of retraction. That may not be necessary if you know that it's coming back to the ACOM region more anteriorly. So you don't really have to do a lot of retraction. And in many cases, especially for swollen brain and ruptured ACOM, one has to do a very minimal gyrus rectus resection to get to the base of the aneurysm. And Sylvian Fisher dissection is often used to get a proper exposure in difficult cases where you can expose all the relevant structures, both A1s, both A2s, recurrent Hubeners, and hypothalamic perforators, so then you can have a proper view. This is not a typical ACOM, but this was a A1 aneurysm. So these are not common aneurysms. You can see the left A1, the aneurysm is coming from the A1, but the wall is very thick, and often these aneurysms can be difficult to endovascularly manage it, but it can be very safely clipped without any need for any stenting or anticoagulation in the long run. So you can see that there is a thick wall here. So if I need to approximate it more closely, that will occlude that A1. But often these aneurysms, this A1 will reconfigure in course of time. I use a temporary clipping very generously. Often 3 to 5 minutes is my maximum temporary clipping, and then dissect as much as being needed. So So this is another man who was in his 60s, came with a stroke initially from a venous thrombosis, was found to have an extensive AVM, frontal lobe AVM, but the sagittal sinus thrombosis, very congested brain. And while waiting for planning for his AVM surgery, he came with a bleed. So I wasn't sure whether he bled from the ACOM, which he had here, which is like a feeder aneurysm, or from the AVM. So when I was planning it, the ACOM region is here. This was the AVM around here. And so after the AVM resection, I need to get to that ACOM from the superior aspects, like an hemispheric approach to expose the ACOM aneurysm. Fortunately, that was an unruptured aneurysm. Otherwise, this approach is slightly more risky as you will be coming from the top. So in terms of deploying the clips for aneurysm, like anywhere else, you've got to be very gentle, very slow.
1 minute, Ramesh.
Yeah, thank you. So I will probably just show you one other one. This is an ACOM aneurysm I operated. Came with a bleed from these two aneurysms, distal antesupplementary aneurysm, one from here and the opposite. This is the one that bled. So it was, none of these were endovascularly treatable. So I had to do a parasitical craniotomy to clip these two aneurysms in one setting. But it was not clippable through that approach, quite high up. So she came back to have a endoscopic approach. So this is the view you get. There's no retraction involved. The right A1, the left A1, and this artery was stuck. This approach can be used in a very selected cases. You have to be super careful in selecting these cases. A good aneurysm will be projecting anteriorly, superiorly. You need to be able to get to the A1 and A2s bilaterally. So this is the exposure. This is the diaphragm. This is the lamina terminalis. The patient had a shunt for the initial subarachnoid hemorrhage. And this is the final sort of approach. So I'm just going to script through. You can see that the aneurysm is being exposed. A1, left, right A2 is here. Left A2 I have already exposed. And the numbing of the aneurysm is thrombosed. So this sort of approach is very unusual, but in select cases it is doable. But thanks, Vladimir, for allowing me to present this case. I'm going to stop sharing now.
Thank you, Ramesh. I believe that you are on the flight, but we have a discussion planned after the session, but I believe that we can
I will stay back as long as possible. Thanks, Vladimir.
Okay, so let's go ahead with the lectures, if you can be with us, which is very much welcome. And so I will ask Henry Schroeder from Greifswald, Germany, to show us his aneurysm. How do you have it? Microsurgical treatment options in cerebral aneurysm. Henry, please.
Yeah, thank you, Vlad, for the kind introduction. Hello, everybody. So I just want to present some cases which are not so frequent, just to show the technique and hope we can discuss whether I choose the right option or not. So the first case is a 47-year-old female. She presented with aphasia and apraxia. And in the MRI, you see already there is an aneurysm in the MCA region on the left side. And you see she had multiple small acute infarctions. And in the MRI, you see a partially thrombosed MCA aneurysm. So this is not a good idea for coiling, of course. So we expose it. And look here, you see here is a small white thrombus in one of the M2 branches. This is one M2 branch. The second M2 branch is the M1 branch here. When we dissect here, you see this, boom, another thrombus is flying away. So it's a clear indication for surgery because of the repeated emboli. So we have, of course, to open the aneurysm to remove the thrombus, otherwise it's not clippable. So we make the same like an endarterectomy. We remove the thrombus and then the changes on the wall. And we dissect as long without peripheral clips. We have just one clip on the M1 until we got the rebleeding from the M2 branches to reduce the ischemic time. So then we clipped it here and we remove more of the clots and we identify the ostium of the M2 branch here. And you see thrombus goes into the vessel and we have to remove all this very carefully to avoid another thrombosis. Here's the second branch. Also, we remove the thrombus here. And only when everything is clear, we can dissect. And then here, I saw we make a hole in the wall close to the M2 branch here. So now we can fold the aneurysm together, and we see here this is the hole what we made. So we have to first place a stitch to close it, because exactly at the origin of the M2 branch on this side. So, and then we can fold it together and we take a clip. And when you clip these aneurysms, this is irrigation with heparin solution. When you clip this aneurysm, you have to leave a little bit of the wall. When you go too close to the origin of the M2 branches, then you get an obstruction, or at least a stenosis. That's why we have taken here a curved clip to leave a little bit of the bifurcation, that we have a good flow. So then we remove the temporary clips, and then we checked it with the microvascular Doppler whether all branches are open. And this is the MR angio, second day post-op. You see here, it's a little bit of the wall, but if you go too close, you have no flow in the branches. And this is now after 3 years, no recurrence, and she has no any infarction anymore. Another case was a 47-year-old male. He had a progressive left hemiparesis and has this space-occupying lesion here. And then in the diagnostics, we see there is a very unusual thrombosed aneurysm of the A1, the left side. You see, this is all A1. Very strange configuration. I have never seen this before. So what should we do with this aneurysm? I think the idea was just to make a proximal occlusion. So when you see here is the aneurysm, partially thrombosed. And then we made the decision, we make an awake craniotomy and make a proximal occlusion and look how he's doing. So we exposed it, and you see here, this is a big A1 going away from the carotid. And then I was thinking, we put it the clip, he was fine, and then we lowered the blood pressure, and then he developed again a weakness. So we said, that's not a good idea to occlude it, and we removed the clip again. This was a clip, and then we removed it again. But anyhow, simply because of the short temporary occlusion time, the aneurysm thrombosed. So then we put them on high pressure. When the arterial pressure was high, then he has no neurological symptoms. And after a while, he adapted to this, and we could wean him off the adrenaline, epinephrine, what we gave to him. And then after 2 months later, we said, this aneurysm might be reperfused, so it's better we clip it. And since the artery is thrombosed, or the aneurysm is thrombosed, it's not a big problem. So we dissect here. This is a carotid T, and you see here we measure the flow. There is flow, and distally is no flow. So we look for the perforators at the carotid T area to leave them all free when we place the clip. And then we occlude the A1 proximal at the bifurcation of the carotid again, just to make sure that the aneurysm is not reperfused and is further growing. And this was okay. This is a clip. And you see 4 weeks after surgery, you see already a little bit of reduction in size of this aneurysm. And then after 3 months, further shrinking. And he was going fine. And 14 months, you see it becomes smaller and smaller, and he is doing well. So just a proximal occlusion in this case. This is again the comparison pre-op and 14 months after surgery. Another case, this is a 70-year-old male, headache, neurological intact. He got an MRI, and you see this aneurysm. And we thought, man, she's 74, no indication to do, just he should come at 6 months with a follow-up MRI. And then he came, and you see it's almost double the size. And then we talked to him, said that's a high risk that this aneurysm will rupture in the future. So we would recommend to do a treatment. But what can we do? The whole thing is the A3. We could occlude it, but then we have a problem. So the only thing what we can do was to make a bypass to have a good flow in the A1 on the side of the aneurysm. So we place the patient with the right side down. This is here the forks, and then we dissect it. You see the aneurysm, and you saw the branch. This is a 3 branches, or the distal branches, A4 branches. And we made the decision to make a side-to-side anastomosis. So we clip both vessels, and then we open it and prepare. And the technical difficulty is the first suture line, because it's down and you cannot turn the whole vessel. So first you have to suture the edge, the edges of the incision of both arteries together. But then the problem is to make the suture line of the lower arterial wall. And we irrigate all the time with heparinized solution. So this is the first suture. And then on the other end of the incision, the end of the arteriotomy, we place a second stitch. I cannot forward the video because this is the old PowerPoint. Sorry. So, but here you see the difficulty is to stitch only the lower wall of the artery, not the upper one. And you have to keep it open. And that is technically not so easy. So I make just interrupted sutures, not the running. And then after the second suture line, we open the clips. You see it's a little bit bleeding, but not much. And then removed all this. And then we put immediately in on aspirin to avoid a thrombus formation. So the microvascular Doppler shows a good flow. And we also made ICG angiography. And then we clipped, make a proximal occlusion of the aneurysm. That's it. And this is our next day after surgery. You see thrombosis in the aneurysm. And the angiography shows that there is occlusion of the aneurysm, but a good flow also here in both areas of the anterior cerebral artery. And then there was a very interesting case. It was a 22-year-old male. He had an ear pain and tinnitus. And then he went to the ENT doctor, and they gave him some medication to improve the perfusion. And then he developed also facial palsy. And then he came to the neurologists. And then they presented us to us. And you see there is an MRI showing a lesion in the internal auditory canal, looking like a vestibular schwannoma. You see the enlargement of the bony canal. So it must be a benign, slowly growing lesion. But the enhancement here was strange for an vestibular schwannoma. I said, I don't know what it is, but just we have to make the surgery. And you see this is CP angle. You see vestibular cochlear nerve in the ICA loop goes in the canal as usual. So we open the canal, excise the dura. And then we went in between the vestibular nerves, and we see a strange lesion looking very suspicious coming from the artery. So we cut the vestibular nerve because anyhow it's not working to get access, and it was an intrameatal thrombosed ICA aneurysm. You see the very broad base. This is all the aneurysm. So we mobilized it out of the canal. That's the facial nerve. Facial nerve we kept intact, of course. And here you see the proximal branch of the ICA and the distal branch of the ICA. So then we were thinking what to do, just to sacrifice ICA or not, but there was a little bit of flow in the ICG angiography. He had no infarction, so we said maybe better we reconstruct. So we took the thrombus out, proximal clip. Then we followed the thrombus in the distal branch. If you have some back bleeding. And I was still thinking, should we simply sacrifice or not? But then I thought maybe it's a young boy, maybe it's better we don't. So we excise the aneurysm. And then we made end-to-end reconstruction. First suture, then 180 degrees on the other side, second suture. Then we placed, again, interrupted stitches, and reconstruct. And then we turn both clips to come to the backside. And then we place another 3 or 4 stitches. And then we remove the distal clip, proximal clip.
Henry, would you have 1 minute?
Yes, I'm almost done. Doppler to check, all good, and then we make ICG angiography. And then we put him on angiography, and here see the suture line. And he's doing fine. He is a hearing loss, did not recover, but facial palsy recovered completely. Okay, then I stop and say thank you for your attention.
Henry, thank you. This was a great case, the last one. If we have the discussion after all the lectures of this session, so I would like to ask Abida, are you with us?
Yes,
Abida
yes.
was here. Yeah, you are here. All right. So do tell us about multimodal management of giant and complex aneurysms, please.
Okay.
Floor is yours.
Can you see my screen?
Yep.
Okay.
It's okay.
Okay. So my presentation is how we make a decision in these complex and giant aneurysms, since I have the option of both hybrid and microsurgical management available. So just run through a few cases to show how our decision making turns out in these cases of giant and complex aneurysms. So as you can see that giant and complex aneurysms are formidable neurosurgical problems, and they have a rupture rate or a mortality rate of 40% when they bleed. And even if they are incidentally detected, we should be treating these giant aneurysms and not leaving them to observation, because when they rupture, the mortality rate is quite high. So what are the challenges in the treatment of this aneurysm is first the size. Second is there is a lot of thrombosis and thickening of the wall. The wall will be calcified. There are multiple perforators and vessels in the vicinity. And there are branch vessels that may arise directly from the aneurysm. So these are the treatment options which are available. So either we do a clipping or clip reconstruction, a bypass with a proximal occlusion or trapping with distal occlusion, and of course endovascular options of coiling, stent-assisted coiling, balloon-assisted coiling, or flow diversion. So let's start with a few examples of locations of cases. So I'll start with the IC or the clinoidal or paraclinoidal aneurysms. So this was a patient we had long back, maybe about 15, 20 years back, when there was no flow diverter available. And obviously, it is a wide neck aneurysm. This patient presented with visual symptoms. She was blind in one eye, and she presented with a lot of headache and visual symptoms. And you see, this is the aneurysm, and this was straightforward, and we went and clipped it. This is a recent case that I did with all the available options to me of both endovascular, coiling, slow diverter, and everything. This was done about 6 months back. This patient comes to my OPD. He has not bled. He comes with headache, and they had investigated him and found to have this aneurysm. So a huge aneurysm that was arising from nearly the bifurcation, but more towards the ACA. So on the video, on the anatomy, you can see that it is more towards the ACP. And I decided to go ahead and clip this aneurysm, and this clipping went on very well, and the patient did well. I don't have the video on this. I have the video, but it only shows the ICG, so I am not showing that. This is now another case that I did. So you see, this is a supraclinoid IC aneurysm with a narrow neck projecting upwards. Now, this is quite a straightforward case for endovascular coiling. And this is what we did. We went ahead in this narrow neck and just went and coiled the aneurysm. And again, the patient did quite well. So now you see that our decision-making has little bit changed. This is a superior hypophyseal aneurysm, which is projecting medially. And this is, again, as you can see, has a very narrow neck. So very straightforward, very good anatomy for endovascular option. So just go ahead, put a microcatheter in and put in coils in this region. And you can see the aneurysm is completely occluded from the circulation. The patient did quite well. Now, this is again a recent case that came to us. You see the irregular, she presented with a bad SAH. You see the irregular morphology of the aneurysm. So yes, this is of course clippable also. But again, you see the neck here. It is a very narrow neck. Since it was a ruptured aneurysm, obviously the rupture status has to be considered. So what we planned for this is flow diversion, because again, the anatomy is very nice, along with a few coils in the aneurysm. And as you can see, we can do this. We packed the aneurysm with a few, I think 5 or 6 coils, and then passed a flow diverter through this. And the aneurysm was excluded from the circulation, and patient did well. She was a relatively, I think, 68-year-old female. So this turned out to be the better option for this patient. Then what happens is if you have a bleb, as we know, microsurgically, bleb aneurysms are difficult to treat, but this is an option with a flow diverter. You can just go across here. You can see the wire in the MCA. The catheter will follow, and then you deploy the flow diverter across the aneurysm. And here you see that the flow diverter has been deployed here in the IC, and this is a delayed run showing that the bleb has been excluded from the circulation. Again, the patient did well. Now, what about this case? Now, this patient came to us during the COVID times when there was a lockdown, when there was no endovascular option available to us. So, of course, this patient presented with an SAH and need to be treated. So, of course, microsurgery plays a very important role in paraclinoid aneurysms, but you have to balance the risks and benefits of both the endovascular and the microvascular options and then plan your surgery. So here you see this is a little bit of a wide neck, a paraclinoid aneurysm, and which was done. We operated this patient. Here, I will quickly run through the steps. So this is the aneurysm that has been exposed. You see how the optic nerve is compressed by the aneurysm. So the surgical option is a good one. This is the ACP that will be drilled intradurally. And you can see the drilling of the ACP. The last core shell of the ACP anterior clinoid process is being removed. And now you can see that the aneurysm has been exposed completely with the ICA just behind posteriorly. And now we are trying to get a grip on the neck of the aneurysm. And here you see that it is there. So this was clipped, and then we opened the aneurysm, removed the thrombus, and readjusted the clip a little bit. You can see that the aneurysm has collapsed. You can see the ICA here. And also the aneurysm, after opening it, we dissected it from the optic nerve. So the optic nerve was completely free, and the patient improved in her vision. Now you see that the aneurysm is open, and here you can see the region of the neck, and that there is nothing coming out from there. And the aneurysm has been excluded from circulation. Now this is another case that I did 15 days back. Now this is a patient who presented with subarachnoid hemorrhage, and you see the morphology of the aneurysm. Again, as Professor Nair said, doing a CT angio when you're planning your surgery is a very important thing in your armamentarium, because it gives, you can rotate it and you can get an exact view of where the aneurysm is located to the bony anatomy, and it really helps in planning your surgery. The key in planning the surgery for aneurysm is having an pre-operative image, a 3D image of where the aneurysm is going to be and how it's going to point, and that helps during the surgery. So here you see this is a wide neck aneurysm, and both the vessels after the bifurcation are appearing to come from the aneurysm. So I did not choose an endovascular option for this patient, and I went ahead with clipping. Here you can see that the Sylvian fissure has been exposed. Here you can start seeing the aneurysm. The ICA is just here. And now I'm dissecting around the neck to identify all the vessels at the bifurcation and to see if there is any other vessel in the vicinity. So that is the middle cerebral artery. That is the anterior cerebral artery. Posteriorly down, you can see the basilar with the bifurcation. This is the optic nerve. This is the proximal ICA, which I'm dissecting so that I can place my temporary clip over it. And now you can see that I'm trying to get a hold on the aneurysm before planning the actual clipping. So now I placed a temporary clip on the ICA and placed quite a large clip to get the aneurysm. And now you can see that this clip has actually got the aneurysm. I'm going to readjust it a couple of times because I want to avoid this kink in the ICA that was coming. And then I see the back wall of the aneurysm, which was not visible to me earlier, to see if there is if the clip has gone through all the way and if there is no other vessel that is come in the clip. So readjusting the clip again a little bit, and then you see that the aneurysm completely collapses. Sorry for that. And this is the ICG after the aneurysm, after clipping the aneurysm, and you can see that the aneurysm is completely excluded from the circulation. And here you see the MCA, and further down, you see the anterior cerebral artery is also filling very nicely. So this is the strategy that I chose for this aneurysm. Then there are some of these aneurysms where if you do a DSA, you will see that there is very good collateral flow on the arterial and the venous phases. The venous phase is important when assessing for balloon occlusion and for occlusion of the ICA. So in this patient, we went ahead and occluded the ICA, and the patient did well post-operatively. So this was regarding clinoidal and paraclinoidal aneurysms. Now coming to the cavernous aneurysms. Now this is one aneurysm where the endovascular option of flow diverter has completely changed the management. But this was an old case where you see this huge cavernous ICA aneurysm. She came to us initially with mild symptoms, but as we observed, she didn't agree for surgical intervention at that time. But in a few months, actually, the aneurysm grew in size. And then we had to actually do a bypass with a high flow ECIC bypass with a radial artery with after ligation of the parent artery. But now with this advent of flow diverter, the cavernous ICA aneurysms can be easily tackled endovascularly. And you see this cavernous ICA aneurysm. Here you see the flow diverter that has been deployed, and you already see stasis in the aneurysm. This is a case I've done 6 months back. These are a couple of my old cases. You see this cavernous ICA aneurysm. The flow diverter has been deployed, and this is a delayed image. And you see that the whole artery has reformed and there is no evidence of the aneurysm at all. Again, another cavernous ICA aneurysm. This is the immediate stasis you see once the flow diverter has been deployed. And this is the delayed image where you see the vessel has reformed and there is no aneurysm that is seen in the artery. This is an interesting case of a patient who came to us after a traumatic road traffic accident, and he developed a caroticocavernous fistula with a pseudoaneurysm. So again, this in the cavernous sinus. So we again went ahead and treated this endovascularly, passed a few coils in the aneurysm, and then deployed a flow diverter across, as you can see here. And then you see this is the delayed image, and the aneurysm has gone from the circulation. Patient recovered in his ophthalmic symptoms. This again, another interesting case. This had been treated somewhere outside, traumatic pseudoaneurysm. Someone had done a coiling. The patient actually came to us with something. He said something came out from his mouth, and it was actually a piece of coil. And the general practitioner had the good sense that he saw the coil hanging in the back of the throat and he didn't pull it. and he just sent it to us. And we could see the coil in the back of his throat. So then we did a DSA. The aneurysm was still filling. So first I went ahead and pushed a flow diverter across this and excluded the aneurysm from the circulation. And then we went ahead and endoscopically cut the coil, and then the patient did quite well after the surgery. So it's an interesting case that we had. Coming to PCOM aneurysms, general rule, I like to clip this aneurysm. They are quite straightforward to go ahead and just, dissect it from the surrounding and clip it. So this is a giant PCOM aneurysm which we have clipped. I'm not sure if I'll have time to run this, but it's anatomically wise, surgically wise, PCOM aneurysms are, I think, one of the good aneurysms to clip. You open the Cillian fissure, you immediately see the aneurysm, you dissect it from all the vessels, you dissect it and identify the PCOM and safeguard it, and you can just go ahead and clip the aneurysm, as you can see here. I will just go further because of lack of time. This is again another case I've done recently. This is again PCOM aneurysm. Now I'll show you this interesting case. This was a small child, 11-year-old girl who came to us with hemiparesis. And this was her CT angio and DSA findings. So her right ICA, she didn't have a right ICA. It was completely not filling from here. It was occluded at the cervical level. The aneurysm had developed on the PCOM and it was being fed from the posterior circulation from the PCA. And the right ACA and MCA were being filled from the left side. So what we had planned for this patient is that we'll do a bypass in this patient to take care of this circulation so that the MCA can be taken care of, because you see this is the MCA that is coming here. And then we would go ahead and plan an endovascular option. So we went ahead and did a bypass. Immediately after the bypass, you see that there is some filling in the aneurysm. After 4 days, we took the patient up for endovascular coiling. And I don't think this is the bypass video. So I don't think I will run into this. And you see that we did this high flow radial artery bypass to the M2 segment. And then we did a DSA after 4 days. And you see that there was flow reversal leading to spontaneous thrombosis of the aneurysm. And we didn't have to do anything endovascularly. And the patient is still following up with us. The bypass is doing well, and she's absolutely fine. So this was published. This is a very delayed image, a 10-year delayed image of this bypass that you can see is functioning, and that there is no aneurysm from the PCOM that was there initially. There are some PCOMs which okay. So
1 minute, Abhida.
Okay. So as I said that we like to clip the PCOMs. We also like to clip the ACOMs. I'm not going to show you that. And the MCAs. So my preference would be to go ahead and clip MC aneurysms, ACOM artery aneurysms, and PCOM artery aneurysms. Some PCOM artery aneurysms we do tend to coil if their age is an factor and if the SAH is quite bad. For all posterior circular aneurysms, we have majoritarily shift to endovascular options. So I'll just quickly show 1 or 2 cases, then I'm done. This is a PCA aneurysm, which I treated with this is partial coiling with a little residual neck, but then the patient is doing well on follow-up with no growth of the aneurysm. This is a young chap with a vertebral artery aneurysm with good flow from the opposite vertebral. So just went ahead and blocked the vertebral artery, and the patient is doing well. And this is another last case that I'm going to show is a large vertebrobasilar aneurysm. This is the DSA of the patient. And you can see it was quite a complex aneurysm to treat. And we planned a strategy to put some coil masses, because otherwise there would be a problem of, sudden thrombosis of the aneurysm with pressure on the medulla. So we passed some coil masses in the aneurysm and then passed a flow diverter from the PCA right down to the basilar. And this is the post-operative result. You can see that the aneurysm is not being seen. And this is the post-op thrombosis. This patient did well, and she's in follow-up, and she's doing quite well with the aneurysm excluded from circulation. So to conclude, giant aneurysms are formidable neurosurgical problems. Basically, the treatment should be individualized based on the lesion, on the morphology of the lesion, and the location of the lesion. And if done well, they have a gratifying clinical outcome. Thank you very much.
Thank you very much, Abhira. Sulci, I am terribly sorry. I have looked for the 3rd lecture, and it was Abhira. So now it's your time to talk on multimodal management. Please.
Okay. Let me share my screen. Okay, I'm Soichia from Goma University, and I'm going to talk about the treatment strategy combining bypass surgery and the endovascular surgery for complicated aneurysms. So these are the aneurysms that are not amenable to orderly endovascular treatment. These aneurysms are the giant aneurysms and aneurysms with wide neck or low dome neck ratio or tiny aneurysms. And so let me share two cases we experienced recently. The first case is the aneurysms with difficulty to access. So this is a patient of the 70-year-old man presenting with a right mild hemiparesis, and the MRI showed a small mass in the left thymus. He was found to have the left P1 large aneurysm. The size was 22 millimeter. And this is the angio architecture. This is a vaginal trunk and the right P1. And the aneurysm was rising from the left P1. And he had a thick PCOM. And he also had the bilateral ICA occlusion, and his vertebral artery on both sides are extremely tortuous, as shown here. So the treatment strategy, we think the endovascular approach via both vertebral artery are difficult, and the catheter manipulation is challenging. So we thought we need to create the conduit for catheter. So this is called the highway bypass method to circumvent the clogged area. So this is how we did. This aneurysm is difficult to approach from the bilateral vertebral artery. So we decided to create the highway bypass using radial artery graft to our MCA, empty portion. And we will be able to advance the catheter through the radial artery graft in a retrograde fashion through the M2, M1, and ICA, and the PCOM and aneurysm. This is how we do as intentional stage aneurysm embolization. The first surgery was the left front temporal craniotomy, and we secure the MCA M2 trunk. And I'd like you to pay attention to the angle of the donor vessel and the recipient vessel. This is not the bypass for the flow augmentation. This is the bypass for the subsequent endovascular surgery. So we have to minimize the risk of the mechanical stress to the anastomotic site. So we try to make the angle of the anastomosis in facing to the proximal side. And after confirming the patency of the aneurysm, we make a 4 weeks interval, and we did the endovascular surgery to embolize the aneurysm along with the apparent artery, which is P1. You see, this is the highway bypass we made. So through with this bypass, we advanced the distal access catheter towards the MCA, and then we embolized the P1 left P1 aneurysm. And the aneurysm was embolized along with the P1, the parent artery, and the patient had no ischemic complications, and the patient was sent to the rehab hospital for his right mild hemipharesis. So in the literature, there have been 5 cases on the bypassable endovascular access, and all these 5 cases, the saphenous vein graft was used. And in this 3 cases report, the cadaveric saphenous vein graft was used. And there will be some very interesting discussion from surgical point of view. First, as for technical aspects, the large cadaveric grafts are better. However, whether it should be a saphenous vein graft or a radial artery graft, I think we were a little concerned that the spasm may occur if we use the radial artery graft, but that's not the case. So in our opinion, both are okay. And as for how to select the recipient vessel, we need to achieve both feasibilities of bypass and vein vascular treatment. And in that respect, I think the retrograde catheterization is a good option. But we have to be careful about the anastomosis angle, because this is not the bypass for flow augmentation. This is the bypass for to embolize the aneurysm. So we have to be either create the useful or safe anastomosis for retrograde catheterization in some cases. And this is another interesting point of view, that optimal interval between first and the second surgery. In one case of the previous, in the previous reports, it was performed in the acute period after ruptured aneurysm, but in other 4 cases, the surgery was conducted 2 to 6 weeks after the initial surgery. But if immediate intervention is possible, I think this strategy can be applicable to the ruptured aneurysm cases. The second case is an ICPC aneurysm with a fetal PCOM artery. This patient was a 57-year-old lady presenting with headache, and during her examination, she was found to have the mass in her right temporal lobe. And actually, this was a giant aneurysm, right ICPC aneurysm. The size was a 27 millimeter. She had persistent primitive trigeminal artery too. And as you see this, her rotation 3D angiogram, she had, there is the thick PCOM arising from the dome of the neck. And she also had the persistent primitive trigeminal artery, but she didn't have the P1 on the right side. In the literature, the fetal PCOM artery is associated with the increased risk of a non-occlusion after flow diverter. According to this meta-analysis, the complete occlusion rate with the cases of the fetal PCOM aneurysm is as low as 30%. So this is our strategy. First, we will coil the aneurysm, and if it ends with the body filling or neck remnants, that's fine, because that will ensure the avoidance of the rupture of the aneurysm in the immediate period, and also it will increase the safety in the perioperative period of the subsequent craniotomy. In the second phase, we will do the V3 and the radial artery and the P2 bypass to attenuate the dependence on the PCOM artery in the patient. And we expect the narrowing of the PCOM artery with the preservation of the perforators here. And the third surgery, which is an option, if we could not obtain the complete occlusion of the aneurysm, we may be able to practice the flow diverter replacement. So the first stage, the coiling was done, and this was a neck remnant, but that's fine, as I said. And this is the second surgery. This is the right transpituous approach. And dura was cut, and also the dura on the pre-sigmoid space was cut, and also the tentorium was cut. And this is the fourth nerve. And by gently retracting the temporal lobe, we expose the P2 segment, and we anastomose the radial artery graft to the P2 segment. As you see here, the broadest field is very important to secure the patency of their graft. And after confirming the patency of the parent artery, then we expose the V3 segment of the vertebral artery, and we anastomose the proximal end of the radial artery graft to the V3 segment. However, the anterograde flow from via the PCOM P1 was too strong, so the flow via the radial graft was very weak. So we try to reduce the flow in the anterograde flow from the P1. We wrap the P1 using the Gore-Tex and the Crip, and we reduce the flow, anterograde flow, and we secure the bypass flow here. And by doing this, we could, this shows the very nice anastomotic flow, the V3 RA P2 bypass, and also this shows the reduced flow. This is a PCOM, reduced flow of PCOM. You see here, this is you see the clip here. Clip here, and the PCOM is becoming very narrow. There is no ischemic complication in this patient, including the perforator ischemia. So we are planning now the flow diverter treatment if we could not obtain the complete occlusion. But now we are watching this aneurysm. So these are the take-home messages. Currently, the endovascular surgery is the mainstream and first, of course, first choice for treating ordinary cerebral aneurysms. However, some aneurysms are not amenable to this endovascular treatment. So for such aneurysms, I think the combination of bypass surgery using graft for endovascular surgery can be an useful option. Thank you for listening.
Thank you, Soichi. And we now have a few minutes for discussion. So let's start with Ramesh. Are you with us?
I am here. Thanks, Vladimir. I'm here.
All right. So let's discuss the lecture of Professor Ramesh Nair about ACOM aneurysms. Anyone?
Do you have any questions? I'll just,
Ramesh, there are people who advocate the opening of lamina terminalis in all bleeding aneurysms.
Yeah, I agree. I think there has been some studies showing that maybe a third of patients may not require any long-term shunts if you regularly open the lamina terminalis. But in my view, I think in unruptured cases, it's not necessary. I try to open less systems as possible if you don't spill a lot of blood around. But I agree. I think when you have opened the lamina terminalis, there may be a less risk of hydrocephalus, but I'm not sure whether you can justify that in all cases.
Okay, thank you. Anyone?
It was interesting because I do open the lamina terminalis, but it's interesting in the last guidelines from the American Society, it showed that there was no evidence that it has benefit to reduce shunting. But I do it when it's bulging. But it was interesting when they analyzed the whole literature, they did not find a benefit.
Yeah, I think, thanks, Ramesh. I think it's important to have a view that if it's just going to be more invasive and if you're going to retract more and if you struggle to open it, I probably prefer not to do that. If it is relaxed and if that is right in front of you, I don't mind opening it.
Yeah. Ramesh, what is the ratio of endovascularly and surgically treated patients in ACOM?
In ACOMs. So I have to say the number of patients we operate in general are much less compared to what we used to operate on ACOMs in the past. Because especially given the fact that after the introduction of the intrasaccular devices, more and more cases are getting endovascularly treated. But we still have a role. I probably see if you ask me a ratio, probably would say around 15% or even less.
Yeah, we have the same. We published coil first in ACOM and clip first in middle cerebral.
MCA, yeah.
I believe that ACOM are very, very suitable for endovascular treatment.
Yeah.
Yeah. Okay.
I'm interested. You showed the case of recurrence after coiling.
Yeah.
I think the strategy to wait for the neck to be
fully developed.
Yeah, developed.
Yeah.
It's an opportunity to do it because surgery without retrieving the coils is not that demanding. And but what is lacking in the practice, because you know the ones that have recurrent treatment endovascular, they tend to have more and more and more procedures, and there is no the ability of the endovascular the IR practitioner to predict how many will recur is still lacking. But again, if you have this neck in a young person, it's a window for opportunity not to lose it.
I agree, totally agree. I think it's better than putting a stent in and then trying to worry about. I find that same in some of the periculose, the distal anti-sublatory aneurysm as well. Once you put a stent in, the surgical options are pretty much gone. So I agree with Ramesh.
Yeah. Ramesh, some 12% will recur after endovascular treatment. It's quite a high number.
Yeah, it is. Yeah, surgery is one-off. I mean, as you know that once you're satisfied with your clipping, then you often do not follow these patients up with the follow-up angiograms or anything else. So that is probably a selling point for us, I suppose, most of the aneurysms.
Yeah, great.
We follow aneurysms up. We make after 5 years always MRI angio because we had some patients who develop another aneurysm at another location. So that's why the rule is after 5 years we follow with MRI angio.
Yeah, that's true. I do that for patients with a family history, but not for random aneurysm. But maybe that may be something which one has to do. But for family aneurysm, even if there is aneurysms on the initial screening, we often recommend another scan in 5 years, and maybe 5 years yearly, every 5 years after that, especially in young patients.
Yeah, so the same. Who performs regular angio, 3D angio after the aneurysm surgery?
After aneurysm surgery, I tend not to do any DSAs unless I have a concern about some remnant. But when I do SA, we do 3D as well. But I don't know among the panelists, anybody would do regular routine DSAs post clipping? Is that what you asked, Vladimir?
Yeah.
We
I
do
had a
CTA.
period when I didn't do anything, and now I got back to 3D angio after any aneurysm surgery. I feel much safer with that.
Yeah.
Yeah. All right, let's go to Henry's. Henry, what do you think would be the sequel if you would close the ICA in your last case?
This is a question. I think nothing would happen because the pica was a dominant vessel.
Yeah.
But I thought you never know exactly. And as a young boy, that's why I thought it's better. But in this case, probably you have seen there was also significant back bleeding when I removed the thrombus from the distal branch. So probably nothing would happen.
Yeah. Okay. Any other questions for Professor Schroeder's lecture?
I do have a great comment because one of the mistakes people do with thick walls aneurysm to put the clip so much against the neck, and they underestimate the internal endothelial apposition and thus narrow the vessel. So I was really impressed when you showed your technique to leave a little bit of the remnant neck from the outside because it includes on the inside, and it's one of the pitfalls in aneurysm clipping, which was a great.
I agree, Ramesh. And also I want to tell Henry that the first case you showed that where you opened the MCA and then opened the MCA the inlets from inside and found the tiny holes of MCA. I had a similar case. The patient was throwing off emboli from the big thrombosed aneurysm, had to be kept on heparin till the day before the operation. Otherwise, he would throw off emboli. So I had to do the same thing, open up. And same like you did, when you put the clip slightly closer, as long as maybe half a millimeter or something, it will block off the exit MCA vessel. So you had to leave a little bit of remnant with the clip. And then I did an angiogram maybe 6 months or 1 year later. The whole MCA got completely reconstituted, almost looked like a normal MCA. So a perfect immediate perfect radiological appearance, not necessary, but often these patients will remodel in course of time.
I would do the same as you did, Henry, but in a regular thick wall MCAs, large ones, I don't care leaving a small remnant on the base of the aneurysm. I never saw any rebleeding or regrowth of this remnant because you have a really thick wall, and I don't think that this will grow.
Yeah.
And it will never rupture. All right, Abida, your lecture. You have few questions on chat, so do please answer them.
Okay. So, do you use adenosine while dissection? No, we do not use adenosine while dissection. We do use a temporary clip, and not very often. Whenever it is necessary, we use it, especially in a giant aneurysm. If you're dissecting around and you think that the wall is not that thick, that's when we use it. Otherwise, these giant aneurysms have quite a thick wall, and you sometimes don't even need a temporary clip. And very small amount of time. My general preference is not to use a temporary clip, but when it looks red and angry, that's when you should use a temporary clip for dissection. And I think the third question is bypass, role of bypass with this combined management available of endovascular and microvascular is very less in our series actually. And we used to do it a lot for cavernous IC aneurysms and some complex aneurysms, but currently the role is very minimal.
I think that it's really less and less usage of bypass, but still, by all means, bypass belongs to armamentarium. Anyone dealing with aneurysms should be able to perform bypass. Probably except for Soichi, who did the bypass in the real depth. I can imagine how frustrated I would be in the depth suturing the vessels. All right, anyone else for Abida?
Abida, do you do endovascular by yourself and clipping?
Yes.
That's good. How many cases you do clipping a year and how many endovascular?
More clipping. little less endovascular.
How many? Around, just around.
I'm not sure the exact number, maybe about 50 endovascular and clipping more.
That's a great number.
Yeah.
Yes. So you are more on surgical side.
Yes.
I guess in Europe now we are coiling much more, that we have like 70% of endovascular, Henry.
Yeah,
you think so too?
Yeah. Yes. So it depends. When they are ruptured, yes. When they are not ruptured, frequently in young patients, I recommend clipping because of the recurrence rate.
Sure.
When they are older, of course, when they are older and you have a growing aneurysm, then we send for coiling. But young people's, I always prefer clipping.
Yeah, the same. But I believe that future will be in endovascular, because there will be actually nobody after our generation who will be able to clip the more complex aneurysm.
Yeah, it may happen. You know, the French say clipping is not more required. Moret say no clipping anymore.
Yeah. You see France. In France, there is nobody who is able to clip an aneurysm.
Yes, probably.
Even the MCA, yeah. They say that we coil all the basilar tip aneurysm, and if you have MCA aneurysm, you just stand the angiogram 90 degrees and you have basilar tip aneurysm of that. And it's easy for them. So they coil everything. All right.
Okay.
Yes, Soichi.
Yeah, I just wanted to say, okay, the important thing is how to educate the young people. You know, if people forget about how to clip the aneurysm, the clipping method will be, just disappeared. Yeah. But it's very important. So it's important how we balance both approaches.
Yeah. We need to keep the ability to clip the aneurysm. That's
right. Sure.
Yeah, that's by all means. Any question to Soichi's lecture on excellent cases with bypass?
Can I ask the panel about the last point of training? Do you think there is a scope currently to modify our clip applicators and clip designs to make it easier for the next generation? Is there anyone who's observing trainees struggling with clip applicators and so on, just to try to make their life easier? What would you suggest?
Yeah, I think there is some room for us to create another maybe better shape or better applicator. So there's we have to create a nicer or more excellent applicator or the shape of the clip. We can still have a room to improve the direct surgery method. That's my opinion.
Because I think if we want surgery to survive, we have to make it simpler.
Yeah, I thought a good point, Ramesh. I think about the trainee and the making the clip applicators and the actual clips better for maybe less complex operation. Right, so I think single shaft, pistol grip sort of instruments and maybe low profile and where you can see the tips very clearly. Because often you find that with some of the old clip applicators, the whole thing will obscure your view. So only with a lot of experience or years of experience, people can clip some of the aneurysm. But if you make it much more easier to see, and then that will be much more easier for the younger trainees. And a good question, I think, is something which we need to work on. For example, the case I shown, the last one, the endoscopic one, without properly designed clips and the clip applicator, you won't be able to clip anything through the nose, I suppose.
Mm-hmm. Yeah. How many aneurysms do you think you need for your training, or how many? When did you feel confident in aneurysms, Ramesh?
I don't know. I'm still feeling confident. Still some of the
500, I know. Mm-hmm.
I don't know. Maybe after 5 years or 6 years, I may have taken me that many years of clipping to feel really better. Still, some of the aneurysm, I still have my heartbeat up.
But can I make a point again on this subject? Because even when you do 500 aneurysm and so on, the proportion of morbidity of simple aneurysm still outweighs the complex ones. There are still mistakes happen in simple aneurysms, and this is
right.
And this is a point that is not emphasized, because a lot of our webinars involved complex aneurysms, but there is a lot of simple aneurysms that have morbidity still happening all over the world.
Yeah, absolutely.
It's
right.
important to share. I think it's important to share the common mistakes we might have, made for the simple aneurysms.
Ramesh, you are right. There are complications even with simple ones. It's 20-minute surgery under the dura. If it's longer, something's wrong. And still you have the complications. Easy, fast, clean, elegant, beautiful, unruptured MCA, and still you may have some trouble.
Yes. We have looked at our experience before and after ICG. What was the common pattern in simple aneurysms? For example, we take MCA aneurysm, and over the years, the number of clips to reconstruct an MCA aneurysm we use are more. In our early experience, we used a single clip. And of course, that will cause the kinking and compromise flow. So we learned from ICG some tricks, pattern recognition, to use more clip, what we call clip reconstruction, as everyone does, rather than just a direct clipping. So this is one example of pitfalls in simple aneurysm.
Yeah. The more angiography you do post-op, the more clip you use. It's also the same thing. All right. Are we done with aneurysms?
Yeah, I think we need to go to the second session, probably.
Yeah. We should go to second session. Well, Pablo planned for 20 minutes or 30 minutes discussion. So we filled that. And now I will give over to Abuzer and Ramesh to chair the second session. Guys, go ahead.
Welcome, Fadi.
Fadi,
Hi, Abuzer.
Hi, Ben.
Hello, everyone.
Giovanni, hello.
Fadi is here.
I've listened. Very, very excellent presentations.
We will continue with the second session about myeloma disease.
We don't hear you well. Something wrong with your micro.
You have some echo there, Abuzer. We don't hear you well. No. You are like
maybe Ramesh can start off, and then Abuzer can.
Yeah.
Right. Okay. So now Professor Fadi Chabal will talk to us about his innovations of how he modified the understanding of what used to be high and low flow bypass, but it is the optimum flow augmentation surgery. Please, Professor Chabal.
Thank you for the great introduction. You summarized it, so my talk is finished. I greatly enjoyed the morning. I congratulate Vladimir, Professor Benesh, and everyone involved in this. Really great talks this morning. Amazing cases from everyone. I really enjoyed it. So what I will go over is how my thinking regarding bypass for Moya has evolved, relevant to what we learned with flow measurements. So it's an evolution over time. And let's make sure we stay on time here. And this is based really on what I learned measuring flow, both in the operating room with the flow probed and outside of the operating room perioperatively with the MR flow measurement software that you see here on the right-hand side. And you all know this. We coined this terminology that there's two types of bypasses in 2006, and bypass for Moya is obviously, as you heard earlier, the term flow augmentation bypass. So we're trying to increase flow because of the obstruction caused by the Moya disease. And one measurement that's very helpful in telling us how well we did or didn't do is this notion of a cut flow index. And all of you are familiar with this, but just to summarize, that the cut flow index means taking the STA, cutting it, and measuring the flow that it can give, and then comparing that to the flow that is obtained, that is measured again once the bypass is completed. And what that tells us is how well the bypass is performing. And it can be nothing or it can be 100%. In Moya, the problem is that often the bypass index is low. In other words, you can take a vessel like this one here. The cut flow is 69 cc's. The anastomosis is performed, and the flow is only 18 cc's. So it's an index of only 27%. So it's flowing on the angiogram, but it's not flowing to its full potential. And the reason for that in Moya, as I'm sure everybody knows, is because in Moya, the territories do not necessarily communicate. So if there's a blockage, let's say in the M1 that extends into the M2 origins, anastomosing of temporal side will not go to the frontal side. So that's why in Moya, most people traditionally have done the so-called double barrel bypass, where we take both branches of the STA and we anastomose them to cover as many territories as needed based on where the flow deficit is. And that's a good surgery. And I'll just show an example of that. So those are the two branches being isolated. Two recipients are identified. We measure the cut flow, 76 cc's here, which is a pretty good STA flow. And then once the anastomosis is completed, you can see that now the cut flow has even increased more. It's 100, and the index is 1 because we have about 65 cc's in one anastomosis and about 15 in the other. So that's the traditional double barrel bypass, which is a good option. And you can see it provides very, very good filling. You can see the flow, 42 in one vessel, 74 in the other. So again, the concept of high flow, low flow is not really relevant. What's important is to know how much flow we have provided. So this video is not playing for some reason now. Let me see if I can fix it. And the reason I wanted to show you this other video is that sometimes the flow is too much. Let me go here. The flow can be too much. So when we try to do this double barrel bypass and the flow is too much, we have to be aware of that and not fall into this trap. So I'm gonna stop sharing for a second and share this video here. Can you see this video playing?
Yeah.
Yeah.
Okay. So you can see here I'm prepared to do a double barrel bypass. And a traditional one. But when I finished the bypass, you see here's the anastomosis, the bypass is performed, it's finished. When I measured the flow in this bypass, it was actually quite good. And I did not need to add another branch because too much flow can be problematic. You see here, I'm measuring the flow in it. I don't remember what it was, but it was pretty high. So what I did instead is I reanastomosed the parietal branch back to leave it as an EDAS. I want to show you the interesting thing. So now the flow is 100 cc's, and really that's too much. But in the EDAS, so that's why I did not do two barrel. But look what happens. The flow is going now retrograde in the EDAS from the scalp back into the brain and into here. And when we measured it, you see it was a negative flow, -6. So again, the flow measurement helps us tailor the anastomosis and decide maybe better what kind of bypass strategy to implement. So going back to the PowerPoint now. Okay, so this is great. We can tailor the flow, but what's the problem? The problem is two things. One is that moyamoya is a progressive disease. So over time, things can change, and we may need to do more revascularization. And two, when we measured flow over time in the bypass with the MRI, what we found is that some of these bypasses involute over time. This was a little bit shocking, and we're not happy to see that, but it's the reality. That's actually what happens. And when in 19 we looked at our data, we had a patency rate of 96% at 1 day, but at 1 year, 74%. And then this was just accepted a few days ago. We're looking at 2024, same thing, almost 31% non-patency when we look at over 2 years in the bypass. So what to do about that? So I started to think a little bit differently. And here, instead of doing 2 end-to-end, end-to-side bypasses, what I would do is I'm checking the flow here. You see the 2 branches are good flow, but the frontal branch, I will do a end-to-side, a direct bypass, end-to-side. And here's the bypass. And then with the parietal branch, I'll also do a direct bypass, but side to side and leaving it flowing. You see, so now you have 2 direct bypasses to revascularize 2 different territories, but one of them is a side-to-side in continuity, kind of like what Henry showed the technique. And that, you see, so this bypass is 35 cc's, and this one here is 59 cc's. So 2 direct bypasses, but one of them is a safety almost bypass. So if things start to change, we also have an EDAS. So that's pretty good. And I did that for a while. But then I thought to myself, what if I can do that, the same thing, a double bypass, side to side and end to side, but only one vessel? And this is where we presented that in 15 in the Moya conference in Berlin. I started doing that now almost 11 years ago in 13, side to side, end to side using a single vessel. And you can see if you take this vessel here, had 110 cc's of cut flow, and one anastomosis gives 67 cc's, the other one gives 40, and you get a total of an index of 1. And you can see side to side, end to side. So here's an example that I think we published. You take the vessel, single vessel, open the dura carefully, leaving the middle meningeal intact, and then you lay it out so you can do a side to side here, cross the fissure, and do end to side on the other side. Now, here's something very interesting. This looked like a great vessel, but the cut flow was only 9 cc's. And I thought something didn't make sense here. This vessel should give more than 9 cc's. What was the problem? Well, it turns out that the problem, there was a vein that was coagulated over the artery that constricting it. And once I cut the vein, look, the flow now is very good. It's 50 cc's. So again, by measuring flow, we averted that problem. So now I proceed selecting one recipient and another recipient, cleaning the side-to-side anastomosis. And then we're going to do the side-to-side anastomosis, cutting the donor first because you don't need temporary clipping here. And then we're going to put the temporary clips on the recipient. Going to do the anastomosis. The only thing different is that I don't put the 2 stitches. I put 1 stitch and I close it like a zipper because I think if I put 2 stitches, it makes it harder. So I just close it, and then I do the front side like Henry showed. And then with the distal end, I do a conventional end-to-side anastomosis like you see being done here. And then you see what we have, 52 to 60 cc's, and the distal end is 15 to 20 cc's. And I think you see the general idea of what the bypass looks like, side to side, end to side, single vessel, double anastomosis. And we published that. There's videos on the internet now. It's been around for a while. And again, the steps, you take the vessel, you isolate it, you clean a side-to-side portion, you open the dura, respecting the middle meningeal. You see here, there's a middle meningeal in the way, so don't cut it, just retract it to do the anastomosis under it. Sometimes a vein is in the way. Again, be careful with the vein. Can put a stitch on it to move it out of the way. Never, never, never compromise a vein, a flow augmentation bypass in particular. And that's the idea. Single vessel double anastomosis, or 1V, 2A, one vessel to anastomosis, also minimax, or Himura calls it a minimax. And the reason for that, it's a progressive disease, and the bypass can involute, so we still achieve direct revascularization of as many territories as needed. We optimize to be able to achieve an index of 1. In other words, take full advantage of what the STA can give, use as few vessels as possible, minimize trauma, not disrupt middle meningeal collateral, but not exceed 80 to 100 cc's. I don't think we need that for Moya Moya. So that's the talk about how this flow measurement changed how I think about this problem. I think I'm still learning, like all of you, and but that's the bypass I like to do preferentially right now.
Thanks, Professor. The discussion will be at the end of the session, and we will continue with the Binzu. Yes, Professor.
Okay, dear colleagues, dear Professor Fadi Shafar and Professor Abuza. So this is my topic. Keyhole bypass for early stage Moya Moya disease. There's nothing to declare. And this is my personal experience in bypass. Until now, I have more than 14,000 bypass totally. And this is for Moya Moya bypass vasculopathy. We published a book and some articles and some English chapters. And this is a normally treatment for Moya Moya surgery. We use STA to MCA bypass combined encephalodural myosynergesis. So this combined approach for Moya Moya is to allow the maximum use of the 3 arteries, the STA or postauricular artery or occipital artery of the scalp, middle meningeal artery of the dural deep temporal artery of the temporal muscle. So normally you can see the skin incision, the bone flap, the dural, and the bypass location was all individualized design according to the analysis of the hemodynamic characters of the patient. So you see this is normally it's a quite a large incision. This is the best possible outcome to cure the Moya Moya. You can see this is a young man, and the bilateral hemisphere blood flow was all come from the ECA branches, and the ICA was totally occluded. But many patients have a physiologically resistance to this large incision and large bone flap, so leading to the continuous disease progression and even loss of the direct bypass opportunity in the future. So if they approach to a Suzuki 6 or 5 stage, actually sometimes you can only do the EVMS. So for Moya Moya early stage, which means Suzuki 1 to 3 stage, in this kind of condition, patient, the distal MCA network was still quite integrate. So in this kind of patient, the main feeder is STA after operation. So this kind of patient, we can use a keyhole bypass. This is 6 months after bypass. You can see the parietal branch of STA is the main feeder of the MCA territory. So the STA is the only feeder for the MCA territory. Select the appropriate location, make sure the delta P is positive and high. Then we can make sure the bypass was very effective. And the preoperative hemodynamic analysis is the key to the success of this kind of operation. So when the delta P is quite small, you can see in the ICG angiogram after the bypass, you can see this is the one short arm of T sign. So this kind of delta P is very small. So almost only after 1 week, you can see the STA, the bypass was almost occluded. Now this is a borrowed case from Professor Zhang. And the underlying logic of the hemodynamic is a Poiseuille's law. So Professor Fadi Chabert just mentioned how to measure the Q. Actually, this is the flow amount, the Q, and I'm offering another parameter is delta P. So delta P is the only dynamic factors that determine the direction of the blood flow and drive the blood flow. The second one is the Bernoulli's principle. This is a law of conservation of the fluid energy. This is the basic principle of the fluid mechanics. And this is the case for AVM. After I occluded the ICA, you can see the PECA now in the main feeder of the niders. So at the same time, after the hemodynamic changes, you can notice that the V4 segment, the delta P was 0. So although the V4 diameter was quite big, it's almost 3 millimeter, but the blood flow was 0, only because the delta P is changed to 0. So this is 7 years after the bypass. You can see the STA was enlarged so much and feeded the whole hemisphere, even the contralateral ICA. This is all because delta P change. But in most cases, there's some competition between ICA and the ECA flow. So you can see the red one is the ICA flow, the green one is the ECA flow. So in Moya-Moya bypass, which doesn't occlude the ICA, and the watershed of the ICA and the ECA is a 3-dimensional curved surface formed by the pressure equivalent points within the blood vessels. So we should know that in MCA territory, it was quite big, and the pressure gradient is quite different in the Moya-Moya, different stage. Like in the early stage, normally they still keep the physiological direction, which means the P proximal is larger than P distal. So, but this kind of patient occupied around 30%. The second pressure gradient of MCA was reversed physiological direction. So this kind of patient, the P proximal was larger than P distal. So this kind of patient, the M2 segment was the lowest pressure segment. So actually, we measured the different pressure in the bypass of Moya-Moya. This is a pressure macrocatheter. And we can detect the pressure parameters in every case. Every case, we can detect 7 different pressures. And we proved that the slot principle in the Moya-Moya case, you can see the blood flow going through the Moya-Moya network, then go to the MCA network, distal MCA network. So the Moya-Moya network plays the role of a slot, which causes a big loss of the energy of the blood flow. And after the blood flow going through the Moya-Moya network, so the MCA to the M4 segment, the recipient M4 segment, the pressure was decreased so much. So it's only 33 millimeter mercury. comparing to the distal of ICA, it's even 85 millimeter mercury. So the mean delta P is 26 centimeter water column. So it's just like a little waterfall from the donor artery to the recipient artery. So when the blood flow goes to the recipient artery, normally in the flow 800 ICG, we can see a red T sign, which means fast bidirection blood flow, means a big delta P from donor to recipient artery. So this is the 4D angiogram. You can see the blood flow going through the STA to the MCA network, then approaching the M2 segment. And this is another 4D angiogram. So determinants of the degree of the reconstruction of the cerebral blood flow depends on the choice of the surgical approach and the location of the stoma, and also depending on the severity of the myomer vasculopathy. In different patients, the ICA residual blood flow pressure is different, and also depends on the pressure balance of the blood flow of ECA and ICA. So the MCA network was quite meaningful for this kind of bypass. So the good MCA network means can bear more blood flow from donor artery. So just as Fadi Chabert mentioned that normally they can take the double barrel bypass. But the poor network, which can bear a small amount of blood flow from donor. So this is if they take the double barrel bypass, it's dangerous for bleeding. So this is a good MCA network. You can see the blood flow reflux to M2 segment, then redistribute the blood flow along the MCA network quickly. But not every case can achieve this kind of effect. So we also use Professor Fadi Chabert's NOVA system to measure the blood flow after the bypass. You can see normally intraoperatively, it's only about 20 to 30 millimeter per minute. But after 7 days, because the big delta P, the blood flow can increase to 77 millimeter per minute. And in some double bypass, even achieve more than 100 millimeter per minute. So on the right side, on the picture of the right side, you can see the good MCA network, and the left side is the poor MCA network. So you see only even in the same patient, the STA carry on the different blood flow, quite different. And in MCA network, if the network was quite good, the STA can enlarge a lot and feeding the big MCA territory. But if the poor MCA network, the STA bypass only 0.9 millimeter, feeding a very limited superficial territory. So MCA network integrity is a condition is quite a determinant for this kind of blood flow volume. So in a patient with good MCA network, the main feeder is STA after operation. So we have two kind of different approach for this kind of keyhole approach, keyhole bypass. So this is a normal keyhole approach in different patient. This is a type 1. The donor and the recipient artery are very close at a certain position. So we can use the 3D angiogram to reconstruct it and decide the approach. Like this patient, you can see the donor artery and the recipient artery was very close, only 1 centimeter. So we can do a very small keyhole and do a direct bypass. This is the incision of the patient. So this is we designed, we will dissect this segment of the STA, and this is the recipient artery under the 3D angiogram. So this is the video. And you can see actually the bypass technique was same as a normal one. So technically it's not difficult. So this is a bypass. After the bypass, you can see the positive of the STA. After the bypass, you can see the STA feeded the whole MCA territory. This is the second type. There's some distance between the donor and the recipient artery. So this kind of patient, you should shift the STA to another position. So we use a curved incision like this. So you can see the MCA network was quite good, but the pressure is quite low. So this is an incision, and we finally, after the bypass, this is a stoma. You can see the, this is just after the STA. You can see the STA parietal branch was enlarged immediately. This is the intraoperative video. So because of the small incision, the pulse of the brain was quite big. So the anastomosis procedure was same as the normal procedure. So this is the before bypass. You can see the MCA network come from the monomer networks, but after the bypass, the blood flow was all come from the STA. So this I also designed some single arm microanastomos instruments. So this is all the this kind of small spatial designed anastomos instruments was very useful in this kind of small keyhole approach. So this is the final result of STA, the keyhole bypass. You can see the stoma was enlarged a lot. So the targeted keyhole STA-MCA bypass is suitable for patients with good MCA network. So technically it's feasible. And the STA is the only feeder in this kind of patient. So select the appropriate location, make sure the delta P is positive. And the preoperative hemodynamic analysis is the key to the success of the operation. Okay, thank you.
Thank you, Professor. And we will get the questions at the end of the session. We will continue with the Professor Vladimir Benes.
Dear host, Professor Abozo, and dear colleagues, because it's already midnight in China, and I arranged 10 cases for yesterday. So would you please excuse me for leaving now?
Okay, sure.
Okay.
Thanks again for
thank
your
you.
great
Thank
presentation.
You. Okay, thank you.
Professor Shubin.
Thank you. Thank you, Professor Chabert.
Okay. Is my screen being seen well?
Yes.
Yeah. All right. I have nothing to disclose while talking on cavernomas. So let's switch from cerebral ischemia and let's go for cavernomas. From a general point of view, cavernoma treatment is about the decision whether to go for surgery or not. And then if you decide for surgery, it's about the approach. And what's true enough is that there is not only one avenue to the lesion. So whichever you are confident with, do choose one. And of course, the main motto is that the risk of surgery must be lower than that of the natural course. And we do not know that, or we do not know enough about the natural course. So let me show you two questions which I have unanswered. Then I shall show you the meta-analysis, which is raising more questions than before, and then few cases. So first question which I have is the disease dynamics. See this case. This is a young lady, and between the first and the third MR is 15 years. The cavernoma is completely unchanged. She never ever had any bleeding except for the first one at the very beginning, and she's doing fine. We didn't offer her surgery, or we didn't even consider surgery much. The other case, just the opposite. This is our pituitary case you see on the left-hand side. So we followed the patient. He was 75 years old. Then in 2014, the cavernoma appeared. 2015, we resected the cavernoma. The patient was back with the bleeding and relapsing disease in another few months. We resected it again, and then another bleeding, which ultimately killed the patient within 2 years from the appearance of the disease. So these are completely opposite and completely contradictory cases. So this is one point. Another case, you see DVA, the patient is doing well, so we did nothing. He's coming in 2018 with the bleeding into the cavernoma. We resected the bleeding. The patient is doing fine. He's back in 2 years with the relapsing bleeding. This is actually organized hematoma with the DVA. This is 7th AIDS, one DVA, another DVA. Going deeper, we find another vein, so it was pretty tricky. This is the lateral pons, and this is the final cavity, and this is after. And now the patient is again doing for another 5 years perfectly well without any changes on his post-op MR. So this is the dynamics. Then the multiplicity. We have multiple cavernomas on the first side, that we have immediately several cavernomas in one patient, and then we have successive multiple cavernomas. This is a patient who came with one epileptic fit due to the bleeding from this cavernoma. He had another 2 cavernomas, but there are patients with many of them. So how to deal with this? Of course, we resected only the symptomatic one, and the other cavernomas we are just following. This is a young girl which I've seen in 1999. She was operated elsewhere. The surgeon encountered bleeding, so he said that this is inoperable AVM. They did angio, there was nothing, but the label of AVM stuck to the girl, and nothing was done. Then her mother called me that the girl is suffering terrible headaches several times a week, and it was bleeding. She came with this cavernoma, which we've resected in 1999. In 2 years, she was back, and you see another cavernoma. We've resected this one, and then there was nothing for several years. She came to us in 2017, 2 kids later, and she had these 2 cavernomas. Since we knew the dynamics of the disease on the first side, we resected even these 2. But there were 15 years of nothing. This is the final image. So we did a meta-analysis, being, let's say, curious what really do we deal with. We had 100 cohort studies, 9,000 patients, 41,000 patient years. And we compared surgery, radiosurgery, and natural course. We were really most curious about radiosurgery because the neurosurgical community was always saying, all right, cavernomas are not is not a disease for radiosurgery. This is the article we've published in JNNP some 3 or 4 years ago, and this is these are the results which are summarized. If we have years, 40 years of life expectancy, and here is the risk of bleeding. The risk of bleeding in natural course in all cavernomas is something like 55% over 40 years. This is what radiosurgery does, the green color. So it nearly cuts the risk of bleeding to half. And of course, the most effective in bleeding prevention is surgery. There is no doubt about that. This is just the brainstem. The brainstem, the natural course, obviously is much worse, 70% risk of bleeding in 40 years. And again, the radiosurgery reduces markedly this risk of bleeding. But still the most effective, of course, is surgery, even with 10% mortality rate at the very beginning due to surgery, because it's stable and you deal with the cavernoma and you are usually ready to. This is something we know about the AVMs, 2.2% yearly risk of bleeding, and we know the rupture morbidity mortality, which is 30%. This figure we do not have for cavernomas. There is no way to find out what is the risk of bleeding in hemispheric cavernomas. And we have this nice image for AVMs, which we cannot construct for cavernomas. But here we have only the risk of bleeding in 40 years' time in a hemispheric cavernomas. See that the natural course we arrive at some 10-15%, and we do not know the morbidity mortality rate, which is reduced by radiosurgery and of course reduced by surgery, but it's really negligible. Should we know the risk of morbidity mortality, the lines would be even more flatter, and we probably would not find any difference in 40 years. This is the traffic sign. This is a map. This is not a general recommendation, but still what we concluded is that radiosurgery has a beneficial effect in cavernoma treatment, so we shouldn't refuse this surgery. Given the low risk of bleeding and even lower risk of serious morbidity mortality after the bleeding in lobar hemispheric cavernomas, there's a question if we should really treat them, if we should resect them, whether we shouldn't just follow them. Of course, epilepsy excluded. On the other hand, brainstem and deep structures, due to the high eloquency, they are much more risky. They really have morbidity, mortality by each bleeding. Surgery provides the best treatment option. And we probably should include those which are within eloquent areas, within the tracts, like pyramidal tract, and these probably should be treated more aggressively, either with surgery or radiosurgery. We have a question of propanolol, but there is no conclusive article, or we do not know enough of that. And thus, it's of course individual decision with each patient based on this knowledge. This is a young boy, he's 18, sudden headache and hearing decrease. This is the cavernoma, which is directly within the eighth nerve. You see here the bed after the resection of cavernoma, the hearing immediately improved. So this is a nice case for surgery where no one would doubt that such a patient should be treated surgically. This is a little more difficult for decision. Brainstem cavernoma, the young boy of 17 years, he's asymptomatic. He only has headache after the physical exercise. Actually, the parents pushed me to surgery because he was on a national team in ice hockey, and this is a big passion in my country. And they expected that he will be playing the American League and bringing money home. So they pushed me to surgery. This was the first surgery from far lateral approach. Whenever I saw the cavernoma and touched the brainstem, all the SCEPs and motor evoked potentials went down. So I closed the wound, did nothing. But then the parents again pushed me. So I went through the midline, through the spinal cord, resecting the cavernoma. I don't know if the guy is playing ice hockey anymore, but he's completely asymptomatic with 2 spinal cords and with no neurological deficit. Again, rather good, but questionable case for surgery. Hemispheric cavernoma, 36-year-old lady, first episode of bleeding, and no one would question surgical indication in this hemispheric case. The same thing, 11 years, first episode, major bleeding, of course, a case for surgery, no doubt about that. What we have, these are old figures, some 6 or 7 years old. In other, which means hemispheric cavernomas, we have had in more than 200 cases morbidity, mortality of 1.2%, and those were non-disabling deficits, 3 of them, negligible number, but still they were deficits. So you cannot do surgery for cavernoma without risk. There is always risk, like with any other surgery. But this is a 53-year-old lady. She's asymptomatic, coming to us with this cavernoma. No difficult surgery. This is after surgery. But by now, I just do not know whether the surgery was really needed, whether this was a proper indication. We could have followed the case. So after this meta-analysis, this is a 19-year-old girl, non-eloquent area, cavernoma on the surface, easy, straightforward surgery. Still, we are following the girl, and we didn't resect the cavernoma. This is a book we've published on that or edited, and there is many data. So if anyone's interested in some more and detailed knowledge about cavernoma, it's there. And I just would like to finish that it's really about the decision, and we should probably in hemispheric cavernomas be more on the conservative side. In cavernomas which we need to treat, we should consider radiosurgery, which definitely has a protected effect. And should we decide for surgery, it's about the approach. Thank you for your attention.
Thank you, Professor.
Thank
And
So,
I will continue with my presentation.
so now, Professor Abuzur with ultrasound-guided approaches to AVM surgery. Please, Professor Angol.
Yeah, I will try to keep shorter because it is the last one. And in these, among these experts, I am the youngest and the least experienced one. I will show some cases of mine. And the usage of ultrasound is not only cranial surgery, in the other in colorectal surgery and the hepatic surgery is used. And most of the time, the red ones is the mostly feeding artery, and the blue ones is the most draining veins. This is from others colorectal and rectal cases. There are a lot of parameters. Also, I don't know most of them, but you can use these parameters. Maybe Professor Charbel can say some things about that. And what is the advantage of the usage of the ultrasound? It is real time. You can see the location of nidus and identification of the feeding and draining vessels. And also it is better better than the navigation. And also post resection, you can identification and identification or complete resection. Also, in this is the flow, and also in the pulsative flow, you can see these kind of colors. And also you can check the post-operatively, if there's a residue or not. This is the pre-operative and the post-operative views. And I will show two cases of mine. And also in Turkey and in the world, most of this case sending neurosurgeons send the gamma knife or endovascular treatment. But if there is a one or two feeder and easy to remove, I prefer to surgical removal. In these AVMs, there's two main feeder from the pericallosal artery and the posterior cerebral artery. And if we go in terms regularly, it is easy to find them. And to use the gravity, I'm using this position. And after releasing CSF, I'm dissecting and try to find the feeding arteries intrahemisphерically. This is the quadrigeminal system to release CSF. And I think this is one of the feeding artery, a big one coming from the posterior cerebral artery. It is not common to see this kind of arteries from posterior cerebral artery going above the splenium. But I'm not sure it is going to AVM or not, because I am continuing dissecting. And then also we dissected from the corpus callosum and the other tissues. And then we are using the Doppler ultrasound to locate the AVM. As you see, is the AVM, needles of the AVMs, and also we can see the feeding arteries coming from the below. And then we will find the other arteries coming from the pericardal artery. And then we put the temporary clip to both feeding artery then control with the Doppler ultrasound, and you can see there's no flow in the area. Then with using bipolar, we close the feeding arteries and remove the AVMs. And after removing, we can control the whole area with Doppler ultrasound. And this is the postoperative view. And another case, also this is the frontal AVM. And feeding artery coming from the carotid artery. And we are doing the skin position, and all steps in this similar. Also, after clip application, we confirm the total disappearance of the blood flow in the AVM nidus. This is our position for interhemispheric approach. And after opening the dura, we go interhemispherically to find describe the feeding arteries. As you see, we found the one feeding artery and describe the other arteries, callosal marginal and pericardal arteries. And describe the A1 with Doppler ultrasound and also feeding arteries. And we put a temporary clip to main feeding arteries and check again and confirm the absence of the no flow. We close this feeding artery. And after closing the main feeding artery, it is easier to remove the area. Like a typical AVM surgery, we remove the AVM from interhemispheric. And also lastly, we close the main draining vein. In the postoperative view. And also postoperative ultrasound. There's no flow in our operative area. This is the postoperative MRI and the angiography. Thanks for listening. By my last slide.
Yeah, thank you very much. now we can have the discussion for the second session. I think from the chat there was only one question, which I think you have answered already. What is the optimum flow in bypass? It's in the chat. The question here.
Yeah, so it depends on the bypass. There's two, like hopefully everybody knows, there's two reasons to do a bypass. If a bypass is being done for flow replacement, which is an aneurysm or a tumor, then the optimal flow is the deficit. So the way to know that is to calculate the deficit. So let's say you have to trap a middle cerebral artery, or you have to trap a carotid. You measure the flow in that carotid, and then you close it and you see how much flow is left. That is the deficit that must be replaced with the bypass, and that should be the optimal flow of that bypass. For flow augmentation, which is MOIA or atherosclerosis, the optimal flow for the bypass is usually around 54 cc's per minute. And this is data that has been shown many, many times. Many years ago, Professor Peter Schmidt looked at that, and we looked at that. But you don't need too much flow. The key in flow augmentation bypass is not to have too much flow. Usually more than 100 cc's is dangerous. So again, to summarize, it's very different. The optimal flow for flow replacement is very clear. You have to measure the deficit, and that's what you need to place. For augmentation, do not exceed 100 cc's.
That's very clear. Thank you. And any questions?
I have a question for Professor Benish, if possible. Vladimir, I really liked your the work you did on the radiosurgery, because as you correctly pointed out, as neurosurgeons, we are biased that we don't really want to accept this data, but clearly in patients that don't have a good surgical choice in the brainstem, to me at least, this is eye-opening data. I mean, it really helps. My question is the side effects in the brainstem. What are the morbidity? Can you comment on that? Clearly it works, but what are the morbidity?
Yeah. Funny, that is the fundamental question to which I do not have an answer. We didn't go for this data. We didn't look at it. We definitely will do this, because that's really the most important one, because these brainstem cavernomas are clearly those which should be treated. And now we need to find the safest way how to treat them. I'm sure that radiosurgery will not have as high morbidity mortality as surgery. Surgery, even in the best hands with brainstem, is still like 8–10%, whatever you do. And I believe that radiosurgery will be lower. But also the protection is not as effective. So then it's balanced between the two.
You know, I will admit that I agree with you. I think that if we are honest, that's exactly what you said. I mean, surgery on the brainstem, you know, we all like to say we do it and we show results, but we know that as a rule, patients get worse after surgery, and then a good portion of them improve. So thank you very much. I think that's eye-opening, and hopefully you'll get to do this work.
Thank you, Fadi. Thank you.
Could I
one factor which probably we are overlooking. The series published are the best series which are. That's not the, let's say, regular and normal work.
Yeah, that's so true. That's very, very important. I agree. May I ask a question of Professor Gungor, if you are still there?
Yes.
I thought it was very clever, the use of the. Can you hear me okay?
Yes, sure.
The use of the ultrasound. So my question is, do you do intraoperative or postoperative angiography, or do you think the ultrasound is enough for you to say you have cured the AVM with no residual?
No, also we use the postoperative angiography and the MRI and CT angiography. I think we must confirm ourselves.
Okay.
I would have one remark. Or Farid, do you want to continue?
No.
Abuzer, as I've seen, if you occlude the feeding arteries, the ultrasound is showing nothing. It looks like the AVM is solved. And that I feel that this is dangerous, because the danger is not in the feeding arteries. Those are easy, you find them, they are on the surface. The trouble is with the deep feeders in the white matter. And if you do not see them with this ultrasound thing, you get the false confidence that you are done. But still you have the worst part of AVM surgery ahead of you. So I would be really very, very careful.
I will be. But I am using this ultrasound to confirm the feeding arteries to preserve the patent normal arteries. Also, you are right. It is difficult to see deep feeding arteries, but mostly, as you know, the most feeding arteries, the big ones, and coming from the main branch, and the feeding arteries coming from the from inside the white matter tracts. There are, in my opinion, there are the smaller ones, because if you can find the bigger feeder, it will be easy to close and remove the AVM.
With the feeding arteries, you know, I have a rule that I do not occlude the artery unless I'm not really sure that it's just the feeder. These vessels may be en passage, so unless proven otherwise, I deal with all these feeders like with the en passage arteries. And again, this may give you the false confidence. Well, you are at the airport. Where do you fly?
Kazakhstan, Astana.
Kazakhstan. Oh, what a place.
Because I need just to expand on that, because I agree the most difficult part of AVMs, especially the diffuse nidus, is to know the edges of the nidus and the perinidal zone. But to augment the question asked by Professor Benesh, if you have enough numbers, how many, I suppose the number of unoccluded AVMs are quite small in all of our hands, but were there many that the nidus did not show filling at the end of the procedure on ultrasound, but the post-operative angiogram showed an early draining vein or some residual nidus?
That's for Abuzer or to?
Yeah.
Abuzer. Ramesh, what I do is that immediately after the surgery, under the same anesthesia, we go for angio.
Yes.
And only then we finish the procedure.
I do that for the pediatric cases, but the most difficult part of an AVM surgery, once you've done a number of them, is still to identify the perinidal zone. And we have done some work with Michael Morgan, which shows that the area does not remodel for significant days, depending on the size, and they can cause problem post-operatively. Now, the question whether to resect the perinidal area, provided they are not adjacent to important white matter tracts, especially in pediatric patients. So we tend to do that after the study in pediatric patients, because a lot of of our AVMs, especially cerebellar AVMs, although the operative videos does not look elegant, but to go wider to the perinidal zone has some advantage in pediatric cases, I think, but I don't know. What do you think?
I fully agree with you. Whenever it's non-eloquent, even in adults, I like to have a safety margin. I do not like to go really on the surface of the AVM. I go a little away from that.
Does it make the operative video appealing, but never mind, it's more effective, yes.
Yeah.
A question, Professor Shah. You showed some really nice cases. Congratulations. But the one that really struck, I think, me and all of us is the one with the coil coming through the nose. And I don't know if you intend to publish this, but I think it would be a very educational case to publish because, I mean, what that means is that those aneurysms that most people say are benign because they are cavernous and they will never cause a problem, and because they're not in the subarachnoid space can cause a problem. I had 2 patients that died because they ruptured their aneurysm into the sphenoid sinus and ultimately exsanguinated through the nose. So I think it would be educational if you, I mean, you clearly show that there's a communication. If this patient had ruptured the aneurysm, they will surely die. So they're not as benign as we think.
So we have published, it's published in Neurology India. And the patient actually came with a gauze piece and he had a coil, little piece of coil on the gauze piece. But lucky for us, he was from a village. The general practitioner saw it hanging. Luckily, he did not pull and he just sent it back to us. Otherwise, it would have been disaster. If he had pulled, it would have been disaster.
It was beautiful, but actually, I don't think that it is that surprising that you can find it in the nose, because whenever you do surgery for previously caused aneurysm, and there is enough time in between, the coils are outside, they are extravasal. So this one was really very sharp going to the nose, but I can really imagine the guy pulling the coil, the surprise.
Yeah.
All right, it's up to me, I guess, because Pablo is not present. So let me thank you all. Let me thank to all participants, which were a nice number. Ramesh, you do not fly all the time. You are still with us. And so thank you for this another IANA webinar, and let's hope to meet you all in the next one. So nice evening, afternoon, morning, whatever, and enjoy yourself.
I'm on the plane.
Thank you.
Thank you. Bye-bye.
Bye.
Bye all.